chapter 3, which starts on page 63 of your text, talking about directional terms for the body, planes, positions, regions, and quadrants. This chapter is important because it talks to us and explains to us how we are going to start to examine the patient, how we're going to talk about the patient's body in relationship to each other and in its position, as well as for diagnostic value in how we talk to other healthcare providers about what's going on with the patient and trying to identify where the problem is in that patient. And we'll see that as we go through today. So, the main items that we're looking at here are directional, anatomic, and body position. Directional is relationship to each other. So if I'm holding my hand up and I'm talking about my elbow compared to my shoulder, compared to my fingers, I'll try to get this on screen, okay? So my shoulder is closest to my body. So that's gonna be proximal in relationship to my elbow because it's closer to my body than my elbow. My elbow would then be distal, meaning further away from my body than my shoulder. So my elbow is distal to my shoulder is proximal to my elbow. My hand then is distal to both my elbow and my shoulder in that situation, okay? Another example would be lateral and medial. So one thing in respiratory care that we do a lot is we draw blood gases. So we'll take a needle, and it's a little bit different than drawing blood out of a vein. We'll take a needle and we'll put it into the artery that's here, it's called the radial artery, because you've got your radius on this side, your radial bone, and then you've got your ulna on this side. And so it's called the radial artery, and we'll put a needle in there in order to draw arterial blood. And that's going to tell us how much CO2 and how much oxygen is in the blood before it goes through the body and gets metabolized. This helps us identify how well the lungs are performing. So when we do blood gases, we'll regularly stick the needle in, and because we can't see the artery, we can only feel it. It's pretty difficult. A lot of times we'll stick the needle in and we don't get blood right away. And so we'll manipulate, we'll feel for that pulse, and we'll say, all right, we need to move the needle either medially towards the center of my hand or laterally towards the outside of my wrist. And so in that case, where my needle is and where I need to move it, I'm going to be using a directional term medial towards the center of the body or lateral to the outside of the body. So that would be an example of a directional term where we're comparing body parts to one another, or when we're doing a procedure, do I need to move in one direction or the other? If I just say left or right, if someone's standing across from me, their left and right is going to be mirrored. So we can't just say, oh yeah, move that left. Well, who's left? Your left or my left? And so it's important that we use a word that is going to be anchored on the patient's body. So using medial and lateral in that position is going to be helpful. Anatomic planes we'll use more or less when we're doing diagnostic exams in order to cut the body in half in one plane or another in order to have a certain view to see, whatever pathology inside of the patient that we need to see, and then how we're going to describe that. And then body positioning terms we'll use a lot of times in performing those diagnostic exams or doing therapies and procedures. We'll have to put them in a specific position in order to perform that procedure or therapy, diagnostic, or assessment. We'll talk about regions and quadrants as well, and I'll kind of give you a little bit more information about those when we get to the slide that shows those pictures. But essentially, quadrants splits up the abdominal pelvic region, so underneath your chest cavity, basically from like your xiphoid process. I'll try to stand up just a little bit here. So if you look at the patient and you've got, typical like nipple line, right below that is where your rib cage starts to cut down. And then right at the end of that, you've got the xiphoid process. You can kind of push in on it and feel it. It's a little bit spongy, because it's a little bone that's connected to the rest of the rib cage with cartilage. And that's called the xiphoid process. So basically from right there down to your waist, your pelvic region, is what we're calling the abdominal pelvic region, okay? And then this up would be thoracic. So that abdominal pelvic region can be divided into quadrants, okay, 4 quadrants, or it can be divided into 1, 2, 3, 4, 5, 6, 7, 8, 9 into regions to better explain where things are happening. It'll make a little bit more sense when I show you the picture as to why we would do one or the other, but we'll wait till we get there to do that. So typical body position here, when we're talking about patients, you can see this man here has his palms facing out, and that's going to be typical. You should, if you're wondering, okay, what does this patient look like? Whenever we're talking about medical terminology, the palms are always going to be facing out when we're referring to terminology, or hands facing forward, as it says here. Whether the patient is standing or lying down, face up, the directional terms are the same. Here are a handful of directional terms in their combined forms. So again, we're taking a combining vowel. In this case, it's that O, which it almost always is. And we're adding it to the word root in order to make the combining form. So something like antero, meaning the front. So basically the word that most comes to mind there is anterior. So anterior means the front. So anytime we add anter or antero to something, we're talking about the front of the patient. Caud or caudo is tail. So if you say the caudal, that's talking about the end or the tail, or like the butt, the downward position of the patient. Cephalo or cephal, so like cephalic, that would be head or upward. In speaking. Disto, we already talked about away from the point of attachment, so like distal. Infer being below, latter being side, medi, like medial being the middle. And then poster or postero, meaning back or behind. That's going to be the opposite of what we talked about up here with anterior. So we'll often see sort of like complementary or mirroring terms. If one means up, there's another term to mean down. If one means front, there's another term to mean back. So antero being front, posterior meaning back in all situations. So if I was going to say the patient, I'm looking at the posterior lobes of the patient's lungs, that's always meaning back here. And if I say anterior, I'm always talking about up here. So when I'm describing a patient's breath sounds, I can use antero and postero in order to do that. Same thing, like super meaning above would be the opposite of infero, meaning below. And then I'm thinking of like caudal. So caudal and cephalo would be opposites of each other as well, or almost the opposite, but in relationship to each other. Okay, so then some prefixes that we use with prefixes and suffixes that we're going to use with these terms. There's not many of them, and they're pretty basic, but they're listed here. We will be using the antero a lot of the time. So, not antero, sorry. I'm trying to select my annotations here while talking to you guys at the same time. The, hopefully, there we go. Ior or ear, and like anterior, posterior. That's one that we're going to be using a lot of the time, and you'll be really familiar with that. So again, basically that's just meaning pertaining to anterior or pertaining to posterior when we're talking about that. Here's a couple other examples that can be used using some of these. So cephalad, caudad, you can see lateral, meaning outward from the middle, medial being inward towards the the middle, and then proximal and distal. Again, they're kind of using the same example that I did with the arm, as well as you can do it with the legs. So some more directional terms just from looking at a different view. So here you can see anterior and posterior. Ventral and dorsal are also basically synonyms. Ventral meaning the stomach region, okay? Dorsal meaning the back region. This can sometimes be used differently with animals based off of their configuration on how they commonly are moving around. You know, they're quadrupeds as opposed to bipeds like we are. So you may find, you know, like if you eventually go into veterinary medicine or something like that, that some of these directional terms are different because of the way naturally the animals are moving around as opposed to humans. And then these two at the bottom, the anterior-posterior and postero-anterior, we'll talk about a little bit more. Those are kind of combining two of the terms, and they look like they're opposite or contradictory of each other. So like, how can you have anterior and posterior at the same time? Well, that's describing a view in a direction of how we're looking at that patient for specific procedures or therapies, like a chest x-ray. So in this example, we see that here is the x-ray plate. And so the film, if you will, where we're going to shoot the x-ray from here out of the machine to the patient. And as it's going to the patient, it is going through the patient and then over onto the x-ray film. It's basically just like a photographic type of film negative that it's using. And the x-ray goes through the body, and the more dense the tissue is, the more of that x-ray is going to get absorbed by that tissue and less of it's going to come out the other side. And the less dense, so like if this is my tissue and you've got some less dense features here and then you've got more dense features here, if that x-ray goes through the finger part where there's tissue and bone, not as much x-ray is going to make it through the other side, and therefore it's not going to expose that image. Whereas if the x-ray part that shoots through the space, it is going to get through and it's going to expose that image more deeply. So it's not just there is something or there's not something, there's different densities of everything. So for example, if I'm talking about my chest cavity and I shoot through right here, I'm going to be shooting through the apice of my lung where there's mostly just air. But if I shoot through right here, I'm going to be shooting through my aorta at the top of my heart, which is filled with more tissue, no air because there's not lung there, and blood. So it's going to be more dense where there's blood and tissue than there is just air. Now, granted, you've got your chest cavity and everything else out here, but that's the same here as it is here. But what's inside differs, and that's what's going to slow down or absorb that x-ray more or less, which is going to change the image on the other side. So when we look at x-ray images like are on the screen, and we shoot from the patient's back to their front, so their front is placed against the plate like that, we're going to call that postero-anterior, because the x-ray is shooting through the back first, moving forward through the anterior of the patient. Opposite on the image on the right, where we've got the x-ray shooting through the anterior of the patient first before it gets to the posterior of the patient. Now this matters when we look at chest x-rays because it's going to change the shape or the size of the organs that are inside the body. So for example, you've got your heart in your patient right here. And when we shoot this x-ray, the x-ray is going to look at this heart, but when it comes out, it doesn't just come out in a straight line, it comes out like a cone. So the x-ray is constantly shooting and expanding as it continues to move further down. So as this x-ray penetrates through here, it's going to be hitting the heart, but you can see Here, it's a very small section, which is accurate for the heart, but by the time it reaches the back of the body and the plate over here, you've got a much larger view. And so in a anterior-posterior X-ray view, it's going to make the heart look larger than it actually physically is. Whereas in a posterior-anterior view, you know, if it's coming through and the X-ray is still doing this, it's not going to change the size of that heart on X-ray. Now, there's benefits to doing a PA and an AP, depending on what it is, what part of the body we're going to look at. But it's important to know that because on every X-ray up here in the corner, it's going to tell you what the position of the body is when they took that X-ray. That way we can see, and then we'll know, hey, if this was shot in AP, I need to expect the heart is going to look larger than it actually is. Therefore, I'm not going to say the patient has cardiomegaly. Okay, megaly meaning bigger, cardio meaning heart. They don't have cardiomegaly because I'm looking at the AP orientation as opposed to the PA orientation. For that reason, we almost always prefer the PA orientation when we're looking at X-rays or when the X-ray tech is trying to take those X-rays. That's what we want to see. However, when we're in the intensive care and our patient is lying in their bed and they've got a ventilator hooked up to them because they've got the coronavirus. Okay, there's the vent, and you've got the RT standing over here taking care of them. And the X-ray technician comes in to actually shoot the X-ray. They're going to put the plate back here, and the X-ray machine is going to come up here, and it's going to shoot through the patient like that. Because we can't take this patient easily and just flip them from front to back just to get an X-ray. And we'll mention that a little bit down the road in just a couple of slides, what we call proning a patient and why we would do that. But in this situation, just to pick up an X-ray, we're not going to do that. It's way too risky to try to flip a patient when they've got an IV, an A-line, catheters, feeding tubes, nasogastric, oral gastric, endotracheal tubes, the ventilator, all hooked up to the patient. It's a complete mess trying to flip these patients. So in this case, almost all of the patients we look at are going to be AP, and it's important for us to know that they're AP for that reason. All right, I hope you guys liked my drawings. So then looking at planes, as far as the diagnostic images, this does a really good job of explaining what does frontal and coronal mean. So frontal plane is sort of that lateral slice straight through the top of the head all the way through the bottom, separating front and back, where the mid-sagittal is like cutting straight through your nose and cutting the body in half. And then transverse would be, just like it shows, basically at the level of the umbilicus, just cutting the patient in half from top to bottom. So if you needed to, you know, how do I know what those actually are quickly and easily? Frontal plane, front to back, and also known as coronal. Nothing to do with the coronavirus, but coronal meaning front. Mid-sagittal would be right to left separation, and then transverse plane would be top to bottom separation. That's just an easy way to learn those. And then here's the information out of the text. I think it's on page 68. Nope, went too far. Okay, I'm not seeing it. There it is. 72, a little bit further in the book than I expected it to be. But giving you the definitions for those things. But essentially, if you remember top to bottom, left to right, front to back, that's going to help you with those. Positioning. Fowler's position is me right now in this chair. So I am sitting upright, basically feet on the floor and in an upright fashion, you know, not quite at a 90-degree angle here at my waist, but this is a Fowler's position. I'm sitting upright. A semi-Fowler's position would be this image that's on the screen where the patient is sort of kicked back. So recliner, and you put your feet out and you just like kick back, right? Like you're gonna watch a TV show. That'd be kind of like a semi-Fowler's position. And most patients do sit in a semi-Fowler's position. Like when we're attentive and working, we're kind of Fowlers, but if we're just chilling at home, typically we like to be semi-Fowlers, and most of our patients at the bed are gonna be in a semi-Fowler's position. The lithotomy position is the typical giving birth position where you've got your legs up in a stirrup and you're prepared to push that baby out. Or if you're getting a typical yearly female exam, you're going to be in a lithotomy position. Supine position is laying on your back. So this guy down here at the bottom here showing supine. You know, when we crawl into bed, typically we're going to be laying on our back, and then if we're a stomach sleeper, then we're going to roll over and be prone. Most of our patients in the hospital are going to be supine. Now, if they're able to, depending on what they've got going on with them, and they're going to want to sleep prone, they can sleep prone if they want, but most of the time, you've got lines coming out of different areas of your body, especially the more critical these patients get, and once they get into the ICU, all of our patients are going to be supine. Most of those patients also have some type of sedative on board to where they're going to be, you know, not necessarily knocked out or in a medical coma, but drowsy to the point where we can still arouse them if we, you know, shake them or call their name. But they're not going to be just up and talking to you regularly unless we pull that sedative off. And so we will keep them in a supine position most of the time. Now the prone position, then when we flip the patient onto their stomach, as that bottom picture shows, will be done for a few reasons in the critical care scenario, mostly having to do with how the lungs ventilate. So this patient who's supine, gravity is pushing down on them from top to bottom. All of their body weight is pushing down. And when we said the posterior lungs back here, because I'm laying backwards and all the gravity is coming this way, the posterior lung segments end up getting smushed. And as a result of that, the alveoli that should be full of air get collapsed. And when they're collapsed, no fresh air can go in and out, and therefore no oxygen can get into the blood and no CO2 can get out of it. And so when we have that situation and it gets collapsed and we can't ventilate them, if it's a severe patient, then we'll turn that patient over, like we see here with the prone position, and those smushed alveoli here now won't have the weight of the body or the weight of gravity on them. Now this area is affected more, but because we just switched them, this spot down here is still open. And as we pump air in, we will start to open up those previously closed alveoli in order to start ventilating them. Now, after a long period of time, these areas in the anterior portion of the body will become smushed. And so then we'll have to flip them back over. And we'll do this typically every 12 to 16 hours on patients, just depending on how they respond to it, in order to try to get equal distribution of air throughout the lung in order to ventilate them. This is something we're seeing done a lot with our coronavirus patients. The ones that actually need ventilators are getting bad enough to where they've got acute respiratory distress syndrome, an acronym that we use is ARDS. And they're very difficult to ventilate. It takes a lot of high pressure to expand those lungs, because what takes place is the body's immune system attacks the virus, and in attacking the virus so violently to get rid of it, it actually causes some physical and chemical trauma to the lung tissue, causing the lung tissue to inflame and become stiff. And when it becomes stiff and inflamed, we can't inflate it very well. We can't get oxygen into it, nor can we get oxygen through it in order to get into the bloodstream. And so we're using crazy high respiratory pressures with these patients to try to open their lungs up and get oxygen into them. And a lot of times then we have to flip them over and prone them in order to be successful with that. A recumbent position would just be lying down. So it's just kind of a catch-all for any time a patient's lying down. It would be opposed to the Fowler's position. They would be recumbent. The Sims position is this gal in red right there laying on the right here. Sort of your typical homicide on the sidewalk chalk outline position. That's your Sims position. And then Trendelenburg, you can see this guy here where the head is below the feet. That's called Trendelenburg. Likewise, we rarely, if we put the patient where their head is above their feet, that's just kind of normal. But remember, a Fowler's position would be like this, semi would be like that. But if we put them in a line with their head up here and their feet down by my elbow, we would call that a reverse Trendelenburg. Whereas Trendelenburg is head down here below the feet. We'll typically do that for certain types of procedures. If the patient's blood pressure is extremely low, we'll put them in a Trendelenburg position to get the blood to flow up to the brain, which is the most important organ to oxygenate and perfuse with blood if we're in a hypotensive or state. And then we'll also use it a lot of times when we're trying to drain the lungs out. So we do something called postural drainage or chest physical therapy, which we do, and we'll put the patient in these positions based off of the lung lobe. So imagine you've got your trachea coming down and then it splits into two main stems. And then from there, it branches out like a tree branch, like branches everywhere, just smaller and smaller and smaller, 23 generations of branching all the way through your lung. So on both sides, you've got these basic like trees coming out of your main stem bronchi. And depending on which area of the lung is affected, like with pneumonia, we need to drain it. So if it's this region here, and this is my airway pointing up to it, I would need to put that patient in a position that is going to vertically drain back to my trachea and out. So I might have to put their head down and put them on their side in order to drain them while I physically beat them in order to get that mucus to clear out of the patient. Very common to also see this with cystic fibrosis patients as well. And then the last one down there, the orthoponia position, where you see this patient kind of just hunched over the pillow. It's called the orthoponia position because orthoponia means that you have problems breathing, the nia, and the ortho, meaning orthostatic. So when you lay down, you have trouble breathing. Morbidly obese patients that have a large abdomen and they lay down and it squashes their lungs when they lay down have this problem. Also fluid overload patients, COPD patients, CHF or heart failure patients often have this. This is where you see those patients who literally sleep in their living room in a recliner, constantly, like every single night. They can't sleep in a bed because if they do it, they can't breathe. That's what orthopnea means. So the orthopnic position then is, I've got to be in this position in order to breathe, because if I lay down, I can't breathe. And that's why it's called orthopnic position. Okay, so here's our abdominal pelvic regions. And here we're talking about the 6 different regions of the body. And so it's more than just the quadrants. But the one thing I want you guys to notice when we look at this is where these sort of joints are made. And in a lot of these areas, especially like this one here and this one here, if you're having pain in this section, what region is that in? Just from a very practical standpoint, if my kid comes up to me and says, "Mom, my stomach hurts," and you're trying to pinpoint, well, I wonder if it's really the stomach or if it's something intestinal, right? And you ask them, okay, well, point to me where it hurts, or you manipulate them. You tell them to lay down and you start pushing in on their abdomen to see where you push, and then they do this grimace face thing, and it's like, okay, that's where you hurt. And if you're pushing and they're not actually saying anything, then it's not that bad. But if all of a sudden you push, and then, okay, then you know that you've hit that spot, and that's truly where the problem is. Because sometimes pain can radiate. You can have a focal point. Like if you got a gallbladder problem right here, I'm sorry, gallbladder's over here. I'm looking at the camera and everything's reversed on me. So looking at the gallbladder here, but you can have pain that radiates all the way up your back and in between your shoulder blades. And that's one of the telltale signs of that is that, yeah, it hurts here, but boy, my shoulder, in between my shoulder blades is just killing me. There's not a problem back here, but that pain is radiating through back to there. So being able to pinpoint that spot is important. So then you manipulate and you palpate, and then all of a sudden, you've hit that spot and you know you've got cholecystitis. Chole meaning gallbladder, itis meaning inflammation, and which we'll talk about in that section. But so here, my point being, you've got all of these multiple center points where it's covering multiple organs. And so if you say, okay, yeah, I've got this pain in my left hypochondriac region, and hypochondriac, chondra meaning cartilage, and hypo meaning below. So it's just below the rib cartilage, like that line right here that I was talking about before. So just below that is your hypochondriac section. You know, if you say that's your area, well, you know, what's up there? You've got a little bit of kidney, you've got a little bit of stomach, but then, well, what if it's your left lumbar? Well, you've got a little bit of kidney, you've got a little bit of stomach, you've got a little bit of intestine. What if it's in the umbilical? You've got a little bit of stomach, you've got a little bit of intestine, you also have vertebrae back there. So it's really hard to sort of pinpoint these areas because they're so small. However, it is a more specific region, which is nice. So just kind of understand that there's pros and cons to using either the abdominal pelvic regions or the abdominal pelvic quadrants. Now, when we look at the quadrants, this narrows it down a little bit more, because if you look at your lower quadrants, you pretty much are just going to be looking at your your lower intestines, and then your bladder. Okay, cervix, female reproduction, male reproductive as well. But then the upper quadrants, you've got, well, left and right, yeah, you've got a kidney on both sides. But then on your right, you're typically going to be dealing with more of your liver. Now, the head of the liver does, you know, reach over into the left a little bit. Typically, the head of the liver isn't what's ever causing problem. When you have liver issues, you're going to feel it on that right upper quadrant. Same thing with the gallbladder. The appendix, kind of, that's going to be more or less in sort of this umbilical region. So left or right lower quadrant. And then certainly gastric issues would be that left upper quadrant where your stomach's at. So the quadrants make it a little bit easier to say, okay, what is it for sure, you know, in those areas, but it doesn't quite pinpoint it as much. Personally, I prefer quadrants myself in dealing with patients and trying to narrow things down. But you may find other providers have, you know, their specific detail that they like through their experience. Some abbreviations, and some of these are acronyms as well. So like RUQ there at the bottom of the list, right upper quadrant. ANT is just an abbreviation. So ANT is not an acronym. Okay, it's just an abbreviation because you're using part of the word in order to just shorten it. Now AP, anteroposterior, that is an acronym. And so LAT, not an acronym, but it is an abbreviation. LLQ, LUQ, those are also acronyms. And so you'll see those used frequently in healthcare. Like I said, basically acronyms are our language in medicine. We speak and write in acronyms like crazy, such that if you know, as you get into medicine and you start using that language and then you start talking to someone else who's non-medical, they can't follow you at all because they have no idea what you're talking about. Similarly, you know, someone comes and pours concrete at my house and they're using all these terms. Like, I guess there's a difference between cement and concrete. And if you're talking to a guy that does that, Like, it's a big deal. They're like, hey, no, that's not right. Don't say that. I had a really good friend that did that, and he always corrected me and thought it was great, because I do the same thing with medical, but he was doing it to me with concrete. So, you know, it's out there in other professions too. It's how we speak. We learn to speak our own new language. Okay, so that chapter is relatively brief. There's not a ton to it. Hopefully that gives you a little bit of time to catch up on chapter 2, which was a little bit longer, and chapter 1, which is just sort of like the learning aspect of it. Chapter 3 does have some really good exercises in it though. So if you look at the text, for example, on page 70, this big exercise page here, exercise 6, this would do you well to go through this. And if you haven't been going through these yet in your text, I would still encourage you to do that. It's going to be helpful to you in learning these terms, and it's going to give you the practice that you need. Learning it, listening to me talk about it, listening to the people on the audio lecture talk about it is only going to do a small amount for you. Where you are going to actually learn the material is by going through and applying it. It's that training aspect of learning something. I'm here to help guide that and to help clarify misconceptions, as well as to sort of talk through this material like we've been doing in order to help you put it into perspective and kind of show you general guidelines on how to learn it. But then you guys actually are the ones that have to go and apply it. And without that application, it's futile to try to learn the material. And in healthcare programs, it's exactly the same way. The healthcare programs that are most successful, and by most successful, I mean the students are ready to go to work and their employers love them, okay? The biggest thing we hear from our employers and our clinical sites is that when your students come to us post-graduation, they're ready to go to work. They don't need to be taught. Basically, show them where the bathroom is. Here's how you use the computers. Here's your name tag, and they're ready to go to work. And that's because we do so much clinical at our program. We do so many hours of applying the information that the students actually learn it. There's other programs, and I won't name them, but nationwide or regionally, you can look at programs that have less hours of clinical work, less hours of applying it, where they're made to apply the information that they've now been fed. And those students, according to the employers, don't do well. They have to train them for 6 weeks to sometimes 6 months before they're ready to go work on their own, whereas our students come in ready to work. And I've been teaching in the program on campus for 12 years. And every single year I go around and I visit all of our clinical sites throughout the state. And then I also am on a state board. So I talk with managers throughout the state, and we have a conference every year statewide. And every year during all of those things, the thing that overwhelmingly I hear from all the managers is, we want your students because they're better. And they say they're better because they come to us ready to work and I don't have to train them. Other students, we don't know what we're going to get when we hire them. So we've sort of built a reputation on that. And because of that, our students get recruited to go work for hospitals, as opposed to having to apply to 13 different hospitals to see which one they can finally get into. That takes a long time, and it takes a lot of dedication on both the side of the faculty, but the students, because they're putting in all of those extra hours of training in order to apply the material, which is making them so good once they finally graduate. So I use that analogy to further just impact the importance of application of this material. You know, I get the totally brain dead feeling that you have at the, 2 o'clock in the afternoon day, and it's like 3 and the sun's outside and you want to go and your kids are running around and all of this is happening, right? I get it. My son's home from school, and for some reason, like, it doesn't seem like he has any homework, gets it done really, really quickly. And so then he's like, hey, you want to go play Xbox? You want to go outside? And I'm just like, yes, but I can't. Like I got to go down into this little room in my house, close the door, and work, because I have to get this stuff done. I have to spend that time applying it. Especially as we get closer to spring, try to resist that. Set aside and schedule your time where you know you're going to be free, and use it wisely. But then set aside time to relieve. Set aside time to hang out with your kids or with your spouse or families, whatever, and unplug. Put the phone in the other room and just relax. Because if you just sit there and you're constantly, oh, email, oh, check this, oh, what about this? You know, that's not relaxing. Your brain needs to unplug and relax. At night, resting, sleeping, sleep science, sleep medicine is a huge aspect of respiratory therapy and what we do. And learning how the brain sleeps and how it rests and recovers is extremely important. We need that in order to be able to be productive the next day. So if we don't have that discipline to learn when we should be learning, but then also to rest when we should be resting, we won't be able to learn the next day when we're supposed to be learning. And then that's just going to continue to carry on, and it's going to cause issues and disruptions in your life. So just a sort of a medical aspect of applying that to your study routines, as well as my experience just with life in being in school as a student. I think more of my life than not. In fact, I know that's the case. So I've kind of learned to live in that environment. Is not when you learn it, that you learn it. So if, you know, here's the thing with any type of assessment, right? So quizzes, tests, homeworks, those are all assessments. And they do two things. One, they give you something to apply. They give you something to practice and to actually train on. But two, then it gives you an assessment of how well do you know the information. So when you take your quiz, and Stacy, I think you said, you know, you studied your brains out and they were leaking out onto the floor, and then you took the quiz and your brain was done and you hated life, but then you took the quiz and you only got one wrong. Like, that's the win, right? That's the assessment, the self-assessment saying, yeah, like I know this stuff, like I did a good job. And then you can take that one area that you missed and you can say, okay, but this I missed. Why did I miss this? And then you can go back and you can say, oh, that was a dumb mistake. I knew that. Why didn't I do that? Or I need to spend more time in this area. And so, you know, the reason we do quizzes and tests is literally so that you can see where you're at in the course. And then that allows us to demonstrate whether you've met the objectives of the course by the end of the course. But you know, all of that is literally just so that you can know, hey, where do I need to put in more time? So if you take that quiz and you get 3 out of 10, that's telling you something, right? It's not telling you that you're dumb or you're stupid or that you don't know the information, but it's telling you something. It doesn't tell you that you don't have the ability to learn. It's telling you that the way I'm trying to learn is not effective. And, you know, something I make my Boise students do, and again, keep in mind, these are full-time working licensed professionals with college degrees already. I make them do an online learning assessment to see what their learning style is. And for me, particularly, when I did my bachelor's degree, I was, you know, 18 to 22 when I was doing that in Bozeman. And the first 3 years of it was like, C's get degrees, like 2.5 GPA. I was more worried about my social life than anything else. And I struggled. Like, I was taking chemistry classes and some other this like science stuff, and I just struggled to learn it, you know, partly because of my motivation, but two, I didn't know how to learn. And then all of a sudden something clicked. One, a little bit of maturity, but something clicked, you know, my third and last half of my third year and my fourth year. And somehow all of a sudden I learned how to learn. I learned how I learn and what I needed to do to make my study time effective in order so that I would retain the knowledge. And once I started retaining the knowledge, it hooked me. Somehow it started then making me passionate about wanting to study, because then I realized the more intelligent I am, the more information I can feed myself, the more I know how to learn, the better I'm going to be at every take discussions, the more valuable I am as an employee or as a prospect to be employed. And it became, you know, a sense of pride to want to do well and to do that. Where before, when I didn't know how to learn, it was so aggravating, it was dejecting, and it made me feel stupid. But I wasn't stupid, I wasn't dumb, and yeah, and I wanted to quit, right? I didn't want to keep going. I was to the point in my degree where it was like, all right, well, I'm far enough that I can't quit. Like, it would be a financially unreasonable thing to quit at this point, when I can just switch my major, take 3 more classes, and kind of get done with it, type of thing. And so I was like, I was dedicated to finishing, but I didn't care what I finished in or how I finished, right? But then sort of that click happened where I learned how to learn, and I realized my whole self-perspective changed, because it wasn't that I was dumb, it wasn't that I was stupid, I wasn't, you know. And I don't know where you guys' paths have brought from or taking you, but I've not met students that have low capacities, right? So you have a capacity as your ceiling, and then your content is how high up that capacity ladder you are. You can think of it as a glass too, half full. So my water bottle is 20-ounce capacity, right? It can hold 20 ounces. But if I don't know what I'm doing, I'm operating in this level, and it stinks. It's not because I don't have the capacity or the ability. It's because something is just inhibiting me from getting there. And so once you break down that barrier and you can operate within your full capacity, like I'm never going to work at 20 ounces. Let's just be honest, right? I'm not. But if I'm working at 17 to 19, that's pretty high efficiency. I'm pretty good with that. And so, you know, like I said, wherever you guys have come from or wherever you're going in your academics and struggles and anything else, just keep that in mind. Like, very few times is it ever that you're limited in your ability by your ability. You have the ability to learn and to be successful. You absolutely do. But somewhere there's a barrier that's causing you not to be able to do that, not to be able to attain that or overcome that. That might be family, that might be kids, that might be a previous divorce, it might be a parenting plan, it might be medical. All of those things I've seen. I've dealt with many of them myself. And you know, the take-home point there is, how do we overcome that? And it's different for each of us, but it is something we can overcome and work around. It's not easy, but don't tell yourself it's because I'm stupid, it's because I'm dumb, it's because I can't do it. No, you can do it. There's this much of can do it. You just got to figure out what's blocking you from the can do. All right. Make the rest of your week great.